So, yeah, thanks to Sigurdur for just incredible presentation. This is truly an amazing project. The largest project where patients give their consent and they're randomized, over 80,000 patients. You know, in our normal studies, we might have 300, 600. A really big study, we might have 1,500 patients. This is over 80,000 patients. It's just mind-boggling, and I do think over time, it will change the way that we approach plasma cell diseases. If we're screening, and we talked about it earlier, these individuals will be tracked, and it helps to know ahead of time that someone has MGUS and might be predisposed to myeloma. So, thank you, Sigurdur. If you want to have a seat here, you can put your coffee down and keep drinking, and we'll take questions. And yeah, if you guys want to come up, you might be able to comment on different aspects.
John, you want to start?
I don't know if you've met Dr. Peter Voorhees, yes, and Beth Faiman. So,
hello.
All right. So,
hi.
Oh, over there. Okay. Yes.
I would like first to apologize to the room because it seems that I always have a question. And apparently I do, I'm sorry. I was wondering, because all of this seems that has to do with multiple myeloma having a genetic component. However, in, I think, my case and in several cases, sometimes there's products like benzene used in sunscreens or other products used in like Roundup, which is something to kill plants or something like that, a herbicide, that can develop into multiple myeloma. So is this because we are already genetically predisposed, or is because there are some products that can actually alter your cells and develop a myeloma by itself?
Yeah.
Because you want to comment on, yeah.
Yeah, so thank you so much. This is an excellent question, and we always need people like you that ask the questions. It's not easy to ask questions, so we appreciate that, first of all. So second of all, this is part of what we are actually studying in Iceland. So what we do is we ask these individuals that gave informed consent, did you work at with diesel, did you work at this factory, did you do, so all these kinds of environmental factors. So we can use environmental factors like prior diseases, like autoimmune diseases, the genetic profile, and see exactly what you are alluding to, like what is the impact of being born with the tendency, and then you add an environmental factor and so on. So the short answer is we do not still know about the complexity of the interaction between all these effects. Usually when we diagnose people with myeloma, they have no known risk factor. They have no prior autoimmune disease. They haven't worked in like a factory that has known to cause cancer. Like most people they have myeloma, and we don't think that it has to do with smoking or their diet or all these kinds of things. But this is what we are trying to understand.
Yeah. And it's difficult, because when you've been exposed to something environmentally, the disease may not manifest for many, many years beyond that exposure. So it may be hard to recall that exposure. And then it's important to recognize, as Sigurdur pointed out, this complex interplay between genetics and environmental factors. There are factors that can mutate and damage DNA, but genetically there may be people that are able to repair that damage better than others, for example. So it'll be fascinating to see what these guys come up with.
In cases, elsewhere around the world where there's been a link between some sort of a toxic exposure and myeloma, there is this lag time which is characteristic for myeloma, which could be 10, 20 years or longer, which does make it so difficult.
Mm-hmm. Right.
Okay. Other questions?
Right here.
Okay, me again. I'm not going to apologize. Luis Perez from Boca. I did a quick search and found that in the U.S. there's 160 million or so people over 40. if you use the numbers here, about 8 million of those may have MGUS. And the headline is, a recent publication in Nature showed that up to 8 million people in the United States could have the precursor to the second most common blood cancer. And it's really a question for the IMF in general. Congratulations on what you're doing in Iceland. It's jaw-dropping. And I'm here as a former reporter and as someone who has made a living promoting science and research. And I'm wondering why I'm not seeing this on the front pages of the New York Times, on the front pages of local papers. Why don't we have reporters at this conference? The IMF is doing great work.
Yeah.
Great stuff. Kudos.
All right.
But
Well,
the challenge is
we'll link you in with our PR, okay?
to go to that next level, because that's how you're going to get to the folks like me who I worked in this space and I didn't know. I knew multiple myeloma, but I didn't know anything. I had back pain.
Right.
And it was 10 months and the damage was done. And there are other people like me. And this science is going to change that, and it needs to be known not just with the people in this room, but beyond this room.
So I fully agree. I'll make a couple of comments and I'll turn it over to Sigurdur. But I mean, we obviously agree that this is going to be hugely important. I think that the one thing that we really agree on is that we want to be very, very sure. So for example, this point that Sigurdur has been emphasizing, we want to be able to be secure about the value of the screening. It's a randomized study, and the first thing that guy from the New York Times is going to want to know is, what showed up in the randomized study? Do you have evidence of benefit? On the other hand, we did take a chance, and we did have that interview with Sanjay Gupta from CNN right at the outset, and that did give us some high profile, and Sigurdur worked really hard. We all had lunch with the president of Iceland, so this is not like we're living under a rock. We are trying to make this visible, but in a careful and a prudent way.
Yeah, I totally agree. Thank you for this comment and a question. So there's a lot of excitement now about screening. So in the beginning, and when we did this video, we were super excited. And then just because we're doing the study, people have been like, everyone just wants to start screening because we are doing the screening study. So I am trying to be like the responsible scientist, saying, okay, we are doing this study to answer the question, should we screen or not? Until we have the results, we just have to wait and enjoy the uncertainty of it. And then when we know for sure, we will let everyone know. And then either we should screen, and then the rest of the world needs to start screening, or we shouldn't start screening, then we shouldn't. Yeah. So I think that's my take on this.
Yeah.
Right.
I mean, when you look at MGUS, the risk of it evolving into something that needs to be treated is about 1% per year. So there are going to be people, especially if they're diagnosed later in life, that are never going to require any intervention for this. So it is prudent to be careful and do the randomized study just as they're doing. But, they have a treasure trove of information, and they can, look at the genetics and, all the answers that they've gotten from their surveys, et cetera, to determine which of these MGUS patients do we need to worry about, and which are the ones perhaps that we don't need to worry about and are not going to go on to develop multiple myeloma in their lifetimes.
Right.
I mean, it's just amazing what they're going to be able to do with this data set.
Right. But the hard endpoint is the survival improved by this early diagnosis and the offering of these interventions? Now, we are, I think, pretty confident the answer to that question is going to be yes, but we don't want to prejudge it. Although we looking to hire a PR firm, but we think that this is going to be the way to go. So what do you estimate, I mean, in terms of the survival, what would be your best guess when we would be able to break the code on that, where we would be able to say, really, it's sufficiently trended.
So we did, like, it's when we plan these studies, you do like a power analysis. It means how many people and how long time do you need to follow individuals, you know, to be able to get an answer to the question so you feel secure. And when we did that, we anticipated that we needed 5 to 7 years of median follow-up.
Right.
So when everyone has been followed, half have been followed for 5 to 7 years. So I think we're like, probably like 3 years from now, we will have the answer.
Okay, all right. So we'll have a lot of questions in the meantime.
Yes.
Well, but in the meantime, we can have lots of side stories about Simon in his tent going around to check on patients and things like that.
Yeah.
We can have a lot of interest stories in the meantime.
And the main thing, you know, should we screen or not, is just one outcome. Then while we're doing that, we have all these different things like the impact of environmental factors, the genetics, smoldering, kidney disease, COVID. We can answer a lot of questions, I think, when it comes to MGUS and, you know, progression and risk factors and everything. But the main thing, the main question is, we have to wait another 3 years probably.
But one point maybe you could comment on is that the outcome for patients with MGUS is not normal.
Right.
I mean, obviously there's 1%, 1 to 1.5% a year that develop myeloma, but for the ones that don't develop myeloma, their outcome is also not normal.
Right.
And so MGUS patients are susceptible to a variety of other things. And so you want to comment on that a little bit?
Yeah, so people with MGUS, they have like low immunoglobulins compared to people that do not have MGUS. That means that they have an increased risk of infections. They also seem to have an increased risk of fractures and thrombosis and other types of comorbidity or other diseases. So it's not only the progression from the precursor to the cancer that's of importance, we think, but it's like the other diseases that people are associated with MGUS. So screening might also, you know, impact that as well.
Yeah, so that there are potential interventions related to those other problems, right?
That they're not chemotherapy for smoldering, but rather like, you know, preventing infections, fractures, all these kinds of stuff.
Right. Number 3, okay.
Carol from Vero Beach. I have multiple myeloma, and my mother had a related disease, amyloidosis,
Right.
correct? So obviously there was something in my DNA that caused my multiple myeloma, but you haven't mentioned that word,
So, yeah.
amyloidosis.
Yeah, so this is LinkedIn, yeah.
So-
Okay.
So the family history as a risk factor for getting myeloma. So if you have one relative that has myeloma or related disease like MGUS, Waldenström, amyloidosis, the risk of the first degree relatives is about twofold,
Yeah.
2 to 3-fold.
Yeah.
So if you have and that sounds like a lot, but if you have a very rare disease like myeloma, like amyloidosis, like Waldenström, even if you double the risk for your kids or your siblings, if you double the risk, the probability of them having the disease is extremely low. So 99 point something of people with MGUS, their relatives will never have any of that. But there are some genetic markers. Now they have 26 that have been described. So you're born with a tendency to develop myeloma-related disease, and there are like markers in your DNA, 25 of them that have been described, that increase or decrease your risk. So you might or may not have that. It might be a chance. Sorry? Right, yeah. So probably that might have impacted to, you know, the family disease in your case.
Right. No, there is, I don't even want to comment on this. In addition to the regular testing, patients are getting mass spectrometry of the protein, which can show if the protein is glycosylated or not. Do you have any information on that or not yet?
No.
Not yet. So that some of the features on the protein will tell you if there's a tendency for the protein to stick together, which is what causes amyloid. And so I guess that's going to be one more project for the future.
So we are screening. We screen for amyloidosis as well. So we ask about neuropathy. We ask about, we check protein in the urine. We do like special staining for that, and check the heart and stuff like that. But amyloidosis is extremely rare. So, but it's part of the project to look at these factors.
Right, and actually, the Mayo Clinic is doing mass spec testing as routine clinical care now, and we have patients that we in North Carolina who come to see us, that testing done at Mayo Clinic, and they'll have the related M spike, and then there's a comment under saying, please, that this may be associated with an increased risk of amyloidosis, and then there's another rare condition called cryoglobulinemia that's also associated with this glycosylation. So it allows us to put on our thinking caps and look really carefully at that patient to see if there's any signs or symptoms of those disorders.
Right. So I think ultimately that's going to be part of the commercial testing, where there'll be those kind of footnotes that will pop up. All right, so I see that we've reached the witching hour where lunch is ready, and I think we're ready for lunch. So thanks again, Sigurdur. Amazing work, and so glad that you came.